So I'm Lisa Kelly. I'm Executive Director of Mental Health Awareness of Michiana, and welcome to our last class of the year. So we've had a great year of education and events. We started with trauma-informed grief and loss. We're ending the year with trauma-informed based assessment. And we're really delighted to have Dr. Nicoletti here. She's a fabulous teacher. And so you're in for a treat if you've never heard her before. I'm assuming people know about our organization, but I'm just going to ask, is there anybody here who's unfamiliar with Mental Health Awareness of Michiana? Great. Okay. So we have classes throughout the year and great events that I encourage you all to come to. If you are not on our email list, we do have a checkbox on the sign-in sheet that we can add you to our email list, and that way you're not going to miss out on anything that we do. Okay, anything else? Jan, anything else you can think of? Okay, great. There are a couple people that are coming in, but I think we should just go ahead and start this time. During the event, our virtual attendees are invited to put questions in the chat box or the Q&A. We have somebody who's monitoring that, and then Taylor, we will let you know, Linda or Elizabeth will let you know. Okay, so Dr. Taylor Nicoletti is an assistant clinical professor and child and family therapy clinical supervisor at the University of Notre Dame Psychological Services Center. As a licensed clinical psychologist, she specializes in trauma-informed, culturally responsive care for children, adolescents, and families, with clinical and training expertise in community violence exposure, suicide prevention, and complex trauma. She provides training and clinical supervision to doctoral students and collaborates with community partners to expand access to high-quality, evidence-based services for youth and families. So highly skilled and also a great friend to have. So welcome, Dr. Nicoletti. Okay.
Good morning, everyone. Excited to be here. Happy you all knew it. So let's get started. As Lisa mentioned, we're going to be talking about trauma-informed screening and assessment, and specifically how do we work with kids and families impacted by complex trauma. So first, some acknowledgements. A lot of this presentation comes from some of the participation that I actually had in training with the Complex Trauma Training Consortium. A lot of the content is related to Dr. Cassandra Kissel's work out of Northwestern. And then we also have the National Child Traumatic Stress Initiative, or the NCTSI, which is a big organization that really specializes in increasing access to resources for folks like you so that on the ground mental health providers can be providing evidence-based care. So you'll all end up having access to all of these slides. We'll actually also send you like a publicly available link. So if you're attending this, you'll have a link where you'll have resources that I'm talking about today, as well as some links to some websites, some screening assessment tools. So my biggest thing is, like, I want this to be as practical and accessible for you all as possible. And that is made possible by all of these other folks. So very much thank you to them and the work that they've done in this area. And then, of course, we can't go on without thanking MHAM. Lisa did a beautiful job explaining MHAM. I am a very good friend of MHAM and the work that we do. And a lot of what we're talking about today when it comes to trauma-informed screening and assessment aligns perfectly with MHAM's mission, right? So eliminating stigma by understanding traumatic responses with compassion. We're going to be building collaboration, thinking about how do we build collaboration across systems that serve children and families. And we're going to be improving access to care for the kids and families in our communities, right? And those are all very important and pivotal sort of missions of MHAM. And so I think this presentation, this training, is a perfect kind of collaboration for our discussion today. And of course, I'm grateful to partner with you all and to learn more about the work that you're doing in the different settings that you're in, and how the resources that I provide today can be a positive impact on the kids and families that you interface. So a few learning objectives. First, we're just going to have a brief overview of what exactly even is trauma-informed screening and assessment. We're going to think about how this framework is essential to providing services to youth and families impacted by complex trauma. And then we'll talk about some key strategies and practical applications to trauma-informed assessment with the kids and families that you interact with in the work that you do. And really the big goal is just increasing trauma-informed screening and assessment competence. So hopefully you walk away today feeling like, I understand maybe one, the difference between trauma-informed screening versus trauma-informed assessment. Hopefully you walk away today understanding, okay, what exactly is complex trauma? We talk about that a lot, both in clinical practice and in research. What actually does it look like? And then what are some key strategies that I can take away back to the place of my work that I can become more confident in screening and assessing for trauma among different families I interact with. Now, throughout today, you're going to see a slide like this. And as Lisa mentioned, I'm a professor as well as a mother, and obviously I'm pregnant and, at the very end of my pregnancy a little bit. And so I think it's a beautiful way for us to take some time to be able to conversate with each other about the sort of skills and things like that that you're doing. And so what we do in the classroom is called Think, Pair, Share. So I kind of give you a minute to think about a topic of your own, and then I have you pair up with a neighbor or someone near you. And then I'll give you a few minutes to kind of conversate about whatever question is on the screen. And then I have you come back together and you share, right? And when I talk to grad students especially, this is usually the most helpful part of their training. They're like, what you're saying, Dr. Nicoletti, that's great. And like what we read, that's also really helpful. But it really is the discussion. Like you all are doing this work, so you're going to enrich each other's experiences. So I really encourage you to feel free to share. And like, there's no right or wrong answer here, right? We're all learning about these topics together. So let's start off here with our Think, Pair, Share. And we can ask the question, what is complex trauma? So it's a very big question, and maybe even easier to ask, like, when you hear complex trauma, what comes up for you in your line of work? So I'll give you a few minutes, like a minute, to kind of think to yourself. And then after that, I'll give you a few more minutes to kind of talk to each other, pair up a little bit. It can be two of you, three of you, whatever. And then after that, we'll kind of come back together and I'll ask someone, few of you to share kind of what came up in your discussions, okay? Okay. Here, exactly. Yes. So right now, having a discussion about what is complex trauma. When you hear the word complex trauma, what comes up for you? Go ahead and start talking with your parents. So.
It's the type of thing like the single thought that it's like something that's to say here. That's there's definitely like sex and and then you know it's not shaped to be it's traumatic. So it doesn't I can become your conflict. So often at least complex or you say then you get the assessment almost every it's not very And later. A
lot of players.
And I just feel like sometimes we always think that we're much related to like you know something and something pieces right like the systemic like I this. Says that three jobs and now my kids are excited. Interestingly, like I see it says. Let's go back. Serious. Or then everyone together. That's yeah.
What things come up? Think of the word complex trauma. Where I give you some formal research definition. What things come up when you think of the word complex trauma or the words complex? Go ahead.
Well, we talked a little bit about how what the difference between complex trauma and trauma would be. And so we were thinking that maybe what makes it complex is the extent to which it impacts a longer period of time, maybe. I mean, we really didn't know. We were just throwing out some things we thought might explain it.
Yeah.
It's hard to say, well, your trauma is not really complex enough, so
Yeah.
we're not gonna work with you, which I'm assuming we're not saying, but basically what we came up with is that we're completely curious about what complex trauma is.
Okay, that's great. I love it. I love it. So you started at the place of like, we know what trauma is. So thinking about, okay, what makes it complex? That's the part that's kind of tripping us up.
Yeah.
That's a great place to start. Perfect place to be. What are other thoughts? Go ahead.
So we thought of it as it's not just one traumatic event.
Okay.
It might be re-traumatized by situations or just repeat trauma. So that
I love that. Yes. Okay. So repeat, that's a good word to use. We'll use that a lot when we talk about complex trauma. So again, going back to our first group, you know, there's trauma. There may be this one specific big stressful event that impacted this child or family's life in a really negative way. But what makes it complex? Maybe it's the fact that it's repeated, right? Okay. I like that. I like that. Other thoughts? Go ahead.
Multiple problems.
Okay.
Or that should be this.
Yes, so repeated and multiple. Great. This is how you're good together as a team, right? Because that's you're on the right track. Maybe one more. Something that came up as you all were talking when you think of complex trauma. Go ahead.
It's usually long lasting, it's not like trains.
Yeah, long lasting, right? So it's not just like something that bothered me for a few weeks, so maybe even 6 months. It's something that goes beyond that, right? These are all beautiful ways to start the conversation. So I'm going to scare you all first with this very big definition of complex trauma, right? And don't worry, we're gonna break this down into much simpler ways, but I'm really big about resources, right? So when you think about the research and what's written in textbooks and all of that, this is the kind of language you're gonna find. You're gonna find where it talks about complex trauma having this dual prompt. So first, it's an ongoing or recurrent exposure to interpersonal trauma, typically originating within the child's caregiver system. So we're thinking about trauma that impacts the child between parents or caregivers or like the primary adults in their lives. So I love how you said that repeated occurrence part, right? That's the first part. The second part of complex trauma is the consequent developmental deficits that affect them. So the last person that suggested long lasting, when you think about long lasting, there's kind of two things you're thinking about. One is going to be, you know, it's more than 6 months, it's more than a year type thing. That's a part of it, sure. But when we're thinking long lasting for kids, you're going to think long lasting developmentally, right? So it's impacted them throughout their development, from the time they learn how to go to the bathroom on their own to learning how to drive a car. Right? Complex trauma is going to impact those developmental skills. Okay. So because I didn't want to scare you into this long definition, I don't love this definition, but this definition is often used in the settings I'm in. I wanted to break it down much more simply. It said there's two parts, like we said. There's repeated interpersonal trauma. usually within the caregiver system. And it impacts development, it impacts emotional development, it impacts behavioral development, it impacts learning. So just developing those basic like learning skills on like truly how to read. Complex trauma impacts the brain's ability to learn how to read, right? It impacts their relationships and their identity. Okay? The other part is that it often involves some specific kind of traumatic event. So this is where our first group was like, we know it's trauma, so we know it's either neglect or maybe emotional or physical abuse. Maybe it's parental or caregiver mental health illness or substance use, or maybe it's parental incarceration or domestic violence. I'm sure you all, our area has done a great job of exposing you all to ACEs, right? Those adverse childhood experiences. So that's what you're going to think of for that part. But it often involves that repeated throughout the child's development. And usually it happens earlier. So we're thinking about, there's a child in our clinic who at 2 years old, he was exposed in utero, first of all, to substance use. And then around 2 years old, parents were using in front of him, kind of exposing him to a lot of really traumatic events, physical abuse between the caregiver system. The child was then placed in a room by himself for a long period of time, right? Those are all different kinds of trauma, but together it's very complex. And it impacted him using the restroom or, learning how to use the bathroom on his own. It impacted his speech development, right? When you're kind of put in an environment where you're not really taught how to engage socially with each other, that's going to affect their learning, right? So we'll get into that a lot more deeply. But I wanted to start off with this definition of complex trauma. So again, we first have that repeated interpersonal trauma. So interpersonal trauma means something happening between the child and usually the caregiver system. And then 2, it's going to impact their development across time, like that long standing across time, right? And then it often involves all the different kinds of traumatic events that we know kids are exposed to. And then we know that complex trauma increases the risk for later trauma, right? That most often kids aren't just experiencing one traumatic event. It's usually multiple traumatic events over time, that once you have 3, you're more likely to have an additional one. And we also know that it's shaped by systemic factors like racism or poverty or intergenerational trauma, or I'm thinking right now, the state of immigration policies in our government, how that's really shaping the lives of kids and families, right? And how things like racism and poverty or intergenerational trauma, how that also impacts like opportunities for neglect or emotional abuse or substance use, right? When families are a part of these structural systems, they're more likely to potentially have these traumatic events happen to their families. So I want to give you maybe 2 minutes, very short time, to talk to your neighbors about, okay, now we have a new definition of complex trauma. What are you like? This is clear, that it makes sense to me. Talk to each other about like, okay, this makes sense to me, or you're like, this still doesn't make sense all the way. I'll give you about 2 minutes to do that. Do that with each other. And the folks on Zoom, put in the chat, what makes sense to me? What's like, okay, I get this part of complex trauma, and then there's still parts that I'm still gonna work on that throughout the next, couple of hours or, hour and a half we have together.
And some of them will just see. Oh, that commission is being and that just was just like it's really carrying on that. So the way she broke it down, then yeah, it's just so space that yeah, so this was so sleep from that area so there's 8 years. That's really so much sense. What do you think? Well, yeah,
It's really good to think about, some of
Yeah, to make a bit of much interest. They weren't. It takes a long time for them to be able to decide their views. Well, that's.
Yeah.
Yeah.
All righty, let's come back together.
Right.
So some of this stuff is starting to kind of make sense. You have to kind of keywords and then my hope is that you still have questions, right? That's why this apparently isn't, that's why it's 2 hours for us to continue to have conversations together about it. So hold on to the questions you did end up having. And by the end of the time today, if you're like, you still didn't answer that question, we can talk more. There's time built in for more discussion. So this slide lays out the difference between trauma-informed screening and assessment. So we just talked about the definition of complex trauma, and I don't know about you, but I'm like, okay, so that's a lot to consider. How do I then go about assessing for that in a child or a family system, right? And so what can be helpful is to start at a place of understanding the differences between trauma-informed screening versus trauma-informed assessment. So screening is usually a brief, structured way to see whether trauma exposures and reactions might be present and if a referral is needed. Assessment is more a detailed, multi-step process. It's often done by clinicians to understand the full picture. So we're looking across history, right? Lifespan or development across time. We're looking at symptoms across time. We're looking at functioning across time. Once again, we're going to be looking at multiple informants, right? So getting information from the caregiving system. But we might also want information from teachers or other kind of educators in a child's life. We may also want information from grandparents. Maybe grandma plays a huge role or auntie plays a huge role in this child's life. And we want information from their perspective on the child's functioning, right? And then we really want strengths. So we could have a whole 2-hour training on childhood resilience in the context of trauma too, right? So thinking about, despite all of these terrible things and traumatic things that have happened to this child or a family system, what has kept them afloat? What has kept them persevering? Because those are the pieces that are going to impact like what we can actually work with in therapy or in intervention or whatever you end up doing. So strengths is also a really important part of assessments. So now that I gave you sort of that brief introduction to the differences between screening versus assessment, I'm curious by a show of hands, or maybe even in the Zoom chat, you can just write in there for folks who are logged in. How many of you are currently doing screening, assessment, both? Maybe neither, or maybe you're still like unsure. Like, I don't know. We call it screening, we call it assessment. It's kind of mixed. So show of hands, how many of you are doing screening? Okay. Let's say you were screening. Okay. How many are doing assessments? How do I describe assessment? Okay. Beautiful. How many are doing both? Screening and assessing. Okay. I mean, like, we don't do that. So that's not part of the work that we do right now, or we just don't know where to even start. Okay. And then how many of you are like, I'm unsure. Tell me more about screening and assessing. Okay. So it's a widespread. It was like a good kind of variation of hands for all of it. So let's dig a little bit more and talk about trauma screening. I'll talk about what it is, who typically does it, and I'll give you some example tools you might encounter and you can even use in your setting. So like we said, trauma screening is typically conducted by frontline workers. They're usually brief questions regarding a child's exposure to trauma. So simply, has this or has this not happened? When we talk about exposure, it's just really yes or no, right? And its impact. Impact being like, is it affecting your sleep? Is it affecting your mood? Is it affecting your learning? Is it affecting your behavior? And it informs whether we need to maybe take a further trauma focused mental health treatment, or if you need to refer them somewhere. Usually we do the screening, hopefully, because at the other side, there's some actions that can be done or some resources that we can provide. So I wanted to provide you some examples of standardized trauma screening measures. Trauma screenings really give us almost like a quick snapshot. Has the child experienced trauma, and are they showing any reactions that might signal a need for more support? It's not meant to diagnose or fully understand the child's history, but it's more of a flag that's like, okay, something's happening here, and there may be some useful, it may be useful to do more assessment. Most trauma screenings fall into two categories. So when I talked about exposure based, those are going to be the things like yes or no. Have you or have you not been in a car accident? Yes or no. Have you or have you not witnessed someone in your community being physically hurt or in your home being physically hurt? Yes or no. And then usually good trauma screeners are going to also ask about symptoms related to whatever you've been exposed to. So yes, I was, in a very bad car accident. And the symptoms are going to be, and I'm having nightmares about it, and it's impacted my eating, or it's impacted my behavior, it's all I think about, right? So those would be the symptoms piece. And what I wanted to do was provide a very clear example. So you all should have with you one of the examples of trauma screeners. This is the child traumatic stress inventory, or child trauma screen, sorry. And this one was developed by the Child Health and Development Institute of Connecticut in partnership with Yale University, trying to give people their dues. But it's a great kind of start. If you are at a place where you don't do any trauma screening and you want to start better understanding the people that you work with or the kids that you work with, this is a great place to start. So you'll see again, that number one, obviously, is just information. So the child information, all of that. Number two is really about exposure or events. So has this or has this not happened to you? Yes or no, right? And then reactions are going to be those symptoms. So have you had trouble feeling happy? Have you had trouble sleeping? Has it been hard to concentrate or pay attention? And this is the child reports. This is going to be what the child reports themselves. Anybody between the ages of 6 to 7. Now, a 6-year-old or maybe even a 10-year-old, I might have one of my students or even myself, if I'm providing the screening, I might do it with them and give them examples so that they understand. And for yes or no, I might have another paper, almost like a pictorial image is what they call it, where it's a green checkbox for yes and a big red X for no. So if this child is like, I don't want to talk to you, I don't want to talk about this, you have them just say yes or no. So they don't really have to like engage with you too much on these difficult topics, right, at the beginning. And then for these questions down here, if it's feeling a little overwhelming to talk about that with the child, I might find a fun way to ask them these questions instead of 0 means never or rarely. I don't know about you, but when I was 7, 8, 9, 10, I was like, what does it rarely mean? So I might have a way to show them on another piece of paper, this is what rarely would mean. Maybe it's, a picture and it's 1 star. Whereas 1 to 2 times per month, I might have a few more stars. Another box, 2 times per week, I might have even more stars. And then 3 times per week, I might have the whole boxes full of stars. And that kind of represents for them how often they experience these symptoms. Okay? So that's what a trauma screening tool looks like. And what I've done here, when you get all of the slides, maybe you already have them, but when you get all of them, you'll be able to click on those, and those are all links directly to trauma screeners. So you can look through them and decide which ones you think best fit your patient population and all of that. I've also provided a caregiver report on the other side. So when you're asking parents about their child's exposures, so it can be a caregiver, grandma, auntie, whoever, foster parent, asking them from based on their knowledge, has this child been exposed to any of these things? And then within the last 30 days, have they had any reactions? Like what reactions they've had? And then the second page is the same exact thing, but distance name. So that's trauma screening. You have one form, and that's it, right? And you, maybe you, because they flag a certain amount of reactions or a certain amount of symptoms, you refer them to a place, or you can provide a resource for them, or you recommend that they do therapy. And that usually is where we stop. Now, let's talk about trauma assessment and how that looks a little bit different. I would say a lot different than screening. So trauma assessment is a much more in-depth process, usually conducted by a trained health provider to understand a child's trauma history, their current symptoms, how trauma has affected their development across time, their functioning across time. It usually has to take place over maybe two or three sessions. And it includes a combination of clinical interviewing, so you're asking the child and the caregiving system questions. We're going to do standardized measures, which we'll give some examples of those. We'll do some behavioral observations and kind of get a picture of like, what's their behavior like? Maybe you watch them while they're in a school setting or a daycare setting. If you're feeling real fancy and you have time to do that within your organization. You get information from other people in the child's life, right? So we recommend talking to a teacher that knows them the best. Or maybe parents are like, I don't feel like teachers really know them. Maybe it's a pastor, a youth pastor, maybe it's a coach. Someone in their life that has a pretty good picture of their functioning and asking them as well from their perspective about their symptoms and functioning. So the goal with a trauma assessment is to really develop a really clear case conceptualization that will guide treatment priorities and help monitor progress over time. So you can probably imagine this level of assessment is much deeper and requires a lot more resources, but is especially important for youth with complex trauma, right? When we went over that big definition, it was like so many different pieces to it. And so in order to really understand, does this child have a history of complex trauma? We really have to do our due diligence to understand the child's functioning. So I want to give us a few seconds to kind of take a minute to debrief everything we've talked about right now. So we kind of went over the definition of complex trauma. We then jumped right into talking about trauma-informed screening and assessment and the differences between the two. And it seems like some folks have screening experience, some folks have assessment. Some folks do both, some folks do neither. So I want to give you some time to kind of think through, why do you think it's important to do screening and assessment of trauma for youth impacted by complex trauma? So you can do this question, but if you're like my students, you'll end up talking about something else like, she said that, and I didn't really think about it, and that's fine too. Together. And on the Zoom chat as well, do the same. Put in the chat, what came up for you as you're thinking about the differences between screening and assessing, the definition of complex trauma, and why is it important to do a good understanding of assessing for complex trauma? I'll give you a few minutes.
Screen items. Started snapshot. So we look at it again. Yeah. Screen treat. So they use absolutely need attention to intervention. Have you ever done situations where after it's like, oh, okay, they don't have this, but they're just gonna why? I was sit on the mobile here. It was like It's like exhausting. I can't do it. It's not hers. I think it's right at the end of this last meeting. There's some times. Yeah. So. So that's just these matters. They're just really. They're days. Here's exactly how. Yeah. Yeah, they do. It's just. It's. Sure. Yeah. For things, that's maybe for sense. It's what I hear. And I you can't do so go down. Yeah, 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 that's really nice. Yeah. Yeah, and that's maybe that. But that's, I think it's just. It's so overthink when they spark. It's great that I are you the kinds of guy. But it's. There's an ass. It's not what. Like I said, you know, done for you like. It's just a good. Then what would you like to your feet? You know, that's. I think I'm fixing to try to be so creative. Actually, that.
Yes.
Still not just. Could do that, so yeah.
To relate this question, or just in general
Let
thoughts
them
of
have the control still. Yeah, definitely.
Yes, we work with parents, mostly in coaching and consulting, so this wouldn't be something I would like pull out the first, second, or even third meeting, but if we keep hitting a wall with some of the brain-based strategies that most of the time work for the children and the caregiver, then I would bring this out and say, I think we need to go a little bit deeper, something might have happened and using this screener for that. Yeah, I love that you bring that up because what you're hitting on is like how different systems and procedures are going to determine when you assess for trauma, right? So there are going to be some clinics where we're assessing sleep, we're assessing for eating behaviors, we're assessing for depression, anxiety, and in there, we're going to throw a trauma screening, right? There are some pediatric clinics in Indiana that are now really into like, first time we see its family, we want to assess for trauma immediately because we know that it impacts their functioning. So they do it on the first visit, right? And there are some clinics or some services or organizations that it may not make sense to immediately, provide a trauma screening right away. That maybe later on down the road, if things haven't been effective, the question becomes, what's the roadblock here? Is this because there's a trauma that's affecting the child's behavior and it's not simply, behavioral management? That's great. Thank you for sharing that. What are others' thoughts? Okay.
I think about it in terms of, and we mentioned it in our small group about kind of like getting to the root cause. When you go to the doctor, they might be able to give you a medication to deal with a symptom, but you're always going to have that condition if you don't get to what's underlying it.
Yeah.
And with trauma, it's the same, same thing. And how do you know what services somebody needs if you aren't screening and then, sending for assessment if that's, it's needed or something more is necessary.
Yes, that's a beautiful point, right? And what you're hitting on is misdiagnosis, right? Where, a child is coming in because they're getting in trouble at school. We diagnose them with ADHD, we put them on medication for ADHD, and still problems persist. And we're like, you don't get it. And it's like, a parent was incarcerated, sure. They're exposed to community violence or gun violence, sure. But they should be able to figure it out by now. And then realizing like, oh, there's something bigger happening here. There's complex trauma, or at least a trauma, and that's impacting their behavior. It's not simply this like neurodevelopmental ADHD concern. Yeah. Go ahead and back.
We talked about that for us, because we were here that another really important thing is seeing our piece of it is the screening.
Yeah.
If we have to make sure not to go over that boundary with a person when you're talking about things that we react to.
Yeah.
Sometimes internally, emotionally, and realize that I would love to help you with this, but I actually cannot. And it looks like this might be something that's affecting you, so we would then refer to the community, to a professional that would do the assessment. But just making sure not to cross that line just out of that feeling that a lot of social work people have, which is like, what could I possibly do to help you right now?
Yeah.
But, and so that we were just seeing how it fits into what we do.
Yeah.
And the screening would be a piece of it that we could do.
Uh-huh.
And then, but just not to start thinking I can do trauma stuff because
Yeah.
I don't know anything about it really.
Uh-huh.
So that's where we saw it fitting into us for what we do.
That's beautiful. Kind of knowing your role, right, in a child's, in the system of care and all, however word we want to use, but thinking about what's my role, what's my training or capacity, and how does it fit into understanding this child's functioning, and what resources can I provide? I think that's a huge part of it. We don't want to be just handing these forms out to families left and right, and then being like, oh, thanks for telling us. Okay, see you later.
Yeah.
Right? We want to come up with a procedure like, okay, if they say yes to these things, what do we do with that data? What do we do with that information? And what you're capturing is like, this is the things I can do. So these are the ways I'm going to ask these questions. Do you mind me asking what organization or?
I work for Goodwill,
Okay,
and we work with people, we work with adults, but we're working with adults with children.
oh yeah,
And, we will work with people that have been incarcerated.
Yeah.
And so that's kind of where we're coming at it. We aren't necessarily sitting though with your child.
yeah,
We're sitting with you while you try to figure out how come I can't reestablish a relationship with my child? And how to navigate that.
yeah,
Because being incarcerated, so many people get through it by saying, I'm gonna be a good dad, I'm gonna be a good dad, when I get out. And then nobody really wants to help you do that, and there's a lot of things blocking you from doing that.
Yeah.
And it could, the child could be the primary thing that's blocking it, they don't want to see you. But working with, so we really only have one person in front of us, but informing them of how this is affecting your child.
Yeah.
And part of this is your incarceration, but there's a lot of other stuff too.
Yeah.
So.
So this is why I never get through all the things I want to get through in a training or in a class, like in a lecture, because I love like learning from you all, the work that you do. So it's a great example of understanding your role, what's your capacity, what's your training. But then also I love how you said like there's one person sitting in front of me, but hopefully what this training or our time together does is shows you kind of like this broader picture of like, yes, there's this one person, but they also are a part of a family system that's often impacted by all kinds of things in life, right? And that can lead to complex trauma, both for the adult, but also for the children in their lives. That's great. Thank you all for sharing. I have a few more questions here, but I want to be mindful of our time and I want to make sure I give you all a break. So let's jump into talking a little bit more about what comprehensive trauma-informed assessment looks like. So unlike screening, how we've gone over, this is the brief kind of picture of just understanding briefly what's happening here, what events have happened to you, yes or no, and then what symptoms you're having on a scale of 0 to 5. When you think about trauma-informed assessment, and from a comprehensive perspective, you're going to look around about full impact of trauma across the child's development, functioning, and relationships. And so, if you're really trying to figure out like, what does this actually look like, and maybe I don't have the capacity to do all of it. Maybe I have the capacity to do maybe 2 of the steps or 3 of the steps, or maybe I have all up until 4. So we'll talk about this kind of more deeply together. So this framework kind of breaks down what trauma-informed, like a comprehensive trauma-informed assessment looks like. So first you're gonna assess, and we've done that. So far in our conversations today, we've understood You need to assess across several domains, trauma experiences, what their symptoms are, their developmental history, their functioning, strengths. We want a full picture, but not just symptoms, but a full picture of the child. Then we're going to gather information for step 2 using a range of assessment techniques. So maybe it is a clinical interview. Maybe we do some standardized tools, and then we do some observations and other strategies we can kind of talk about later. But really kind of gathering a lot of information, a lot of data to get a good picture of this child and their functioning. And we're going to collect this information across multiple perspectives or reports, right? We've all probably worked with families or even, you know, 2 adults where you ask them a question and you get 2 very different answers. And you're like, you live together? Like, how did you come up with that, right? So it's helpful for us. Parents, caregivers, they may have 2 very different opinions or perspectives on a child's functioning, and that's going to enrich our data. We want to get that information. We want to get information from teachers, other people in the community, really the folks that interact with the child the most. You want to get information from them. And then you want to evaluate, you want to look at how the youth and the caregiver are functioning over time. So trauma responses can shift, and we want to capture any improvements or increases in need throughout the time that we assess with them. And then our step 5 is to facilitate. So we use the assessment process itself to build engagement, trust, collaboration with families. Asking thoughtful questions is actually a part of trauma intervention. So we might think that there's the assessment or like the screening of trauma, and then there's the treatment of trauma. And I think, sure, we can, like, if we want to parse those things apart, we can do that. But I think in real practice, in the work that you all are probably already doing, assessment can be healing. Assessment alone, asking these sorts of questions in trauma-informed ways, can be an intervention, right? Simply saying, this is really difficult to talk about, but the one thing I know is that the more you talk about it, the less scary it is. That's an intervention. That's psychoeducation. That's like the first 3 sessions of trauma-focused cognitive behavioral therapy, right? So thinking about how do I use my assessment or screening tools in ways that are like just nuggets of intervention for kids. We don't have to be the therapist that does the whole 16 weeks of intervention, but realizing the power that you have of saying, like, you know, this may not be the best place to talk about everything that's happened to you, but I just want to say you are so brave to share this with me right now. That takes a lot of courage to do that. And a lot of kids have a really hard time with that. And that alone shows me that you're going to be okay. We're going to figure it out. I might not be the one to help you figure it out all the way, but I can get you the resources to figure it out. So you see how that like small piece of like instilling hope, instilling some psychoeducation can be really helpful for families, as opposed to, here's a form, fill it out, thank you, okay, you know, because that's avoided. And we know trauma and anxiety, like that's what keeps it going, is avoiding these difficult conversations. So where are we at? That was facilitate, thinking about how do we build engagement and trust, even throughout the assessment screening process. And then if we get lucky, we get to step 6, where we can apply everything we've learned to come up with a treatment plan. And we identify goals or priorities, or what are the most helpful next steps. Usually we're looking at all the information we gathered and we say, like, okay, what is the worst thing that's happening right now? And maybe like this child is not going to school at all. Okay, so that's one of the worst things. So maybe we can figure out, like, how do we get involved in some education system? Or maybe the worst thing is this child is not sleeping at all because they're constantly having nightmares. You're going to maybe prioritize that. So whatever kind of, as you're gathering this information, you kind of come up with a priorities list, and then you apply that assessment information to drive your treatment plan. So that is kind of the big picture of how we think about comprehensive trauma-informed assessment. Another way that I like to break it down for the clinics that I'm a part of and training students on how to do trauma-informed assessment is sort of thinking about 5 different domains. So the first domain is trauma or loss history. What types of trauma or loss has the child experienced? And you can figure that out in a screener. You can figure that out in a more formal assessment. You can do that in a clinical interview. And then you have developmental history. So where were they chronologically, based on their age? And at what point did these events occur? So maybe exposed in utero. Okay, so that's 0. And now maybe they're 17. So let's kind of walk through their developmental history, both with the child or the teen as much as they're willing to share, but maybe with a caregiver to get a really good picture of what their developmental history has looked like. You also want to consider milestones or developmental delays. We know that a child's developmental stage deeply influences how they make sense of their trauma. So if the trauma happened when they were 5 or 6, the same exact trauma that happened to a 16-year-old, they're going to interpret that differently. They're going to talk about it differently. They're going to see themselves differently. So you really want to get a good picture of when the trauma happened to understand kind of what their symptoms are essentially. And then we have trauma responses. So this domain focuses on symptoms, functional impact. So we're exploring emotional functioning, we're exploring behavioral, somatic symptoms, right? Somatic things being like, my stomach hurts, my head hurts. We do it all the time, right? Lots of kids exposed to trauma are often in the nurse's office if they're at school because they're experiencing a lot of physical or somatic symptoms. We want to look at what's their aggression like, what's their withdrawal like, any risky behaviors that they're engaging in. So that's the trauma response. And then you have the caregiver or family history and functioning. So how does the family or caregiver's trauma or loss impact their ability to support the child? So this is always interesting in our clinic when we ask parents, tell me about your any traumatic events. They're like, here for this one. We're not here for me. And so explaining like, oh, yes, 100%. And for us to better understand their functioning and your ability to support them, it's going to be really helpful for us to also understand your experiences. We've all been through things and they shape the way that we respond to adversity or stress. And so it's going to be helpful for us to know. Now, we don't need to get into every single thing that's ever happened to you, but oftentimes kids who are exposed to trauma, their parents unfortunately were too. And that really shapes how we have family conversations about it. And so I might give examples and say, like, we don't have to get into it today, but eventually, if you think it would be helpful for us to know about how stress impacts you, you can share that with us because we want to better understand your child. And then, like we talked about earlier, strengths. So we always want to make sure we ask what strengths or resources it gives them this child, this family, their community. We consider coping skills, any supportive adults in their life, any faith communities, cultural strengths they may have, school resources, hobbies that they're interested in. And so we want to ask, how have these strengths helped them survive adversity so far? Despite all of the things that have happened to them, they're still going. So what has kept them still going? So together, these 5 domains give us a real holistic view. A comprehensive framework like this helps us to integrate the needs and strengths in ways that truly guide treatment, case planning, and engagement with the family. And it takes a lot of work, right? Like I did a lot of training in this sort of work, but I feel very, very passionately that you should not have to spend years in a doctoral program to know how to do this. Like the whole reason why I went to grad school was because I understood like trauma is impacting my family, my neighborhood, and I want to be able to bring these tools back to help have a positive impact, right? And so I think we have about an hour left together to talk about it. But I'll give you all a break, and I want you to think about what stuck out to you so far in our conversation, what feels like very doable, and what feels like this feels really big and scary and not even impossible for me right now in the organization that I work in. So let's have maybe a 10-minute break. How does that sound? I feel like are there 2 bathrooms over there?
Yeah. I
Okay,
can lead you to some other ones, so.
there we go. Okay, so I'm thinking about 10 minutes, people trying to get in and out. But since we have someone who's willing to help us go on an adventure for some more bathrooms, I'll give you.
I can't stop.
10 minutes, let's see what time is it. So we'll come back at 11:10. We'll give 13 minutes. Go ahead, you have a question? What is this for the basis? Can we come back and talk about it? We'll start there. Okay. How does this correlate with ACEs? Okay, we can do that. Okay, we'll see you at 11:10. Okay. Help yourself to like, as you call
He's a cause.
We can jump back in together. And I wanted to offer kind of another way. So the previous slide that we had sort of looked at the domains of comprehensive trauma informed assessment, kind of the questions that might be attached to each of them. I thought this might be another helpful way to see what this actually looks like. And again, these are big domains, right? And so I want to offer you to almost think of this as like, this is a range of ways that we can understand the impact of complex trauma or how we do trauma-informed assessment. It's beautiful if you're able to do them all. I run a clinic that like wants to be like trauma-informed assessment is our thing, right? And we're still figuring that out, and we don't always do all of these, right? So I say that to say, start where you can, right? You can check off like, oh, we are really assessing trauma, loss, and history. We're asking about childhood. We're asking about exposure to domestic violence. We're asking about, you know, any traumatic losses that could have occurred. And maybe we're not really getting into developmental history, so we can start asking about developmental history, and it stops there, right? Or maybe you're doing a good job of understanding the strengths of the family, the child, the caregiver, the family system, and considering how those strengths can improve, right? So I wanted to just offer that as like, we're checking things off. We are not being perfect at this job, but we are reaching for that. Like, this is the ideal way that we understand trauma-informed assessment. We had a great question towards the end, right before our break, about ACEs. So how do adverse childhood experiences fit into this larger conversation about trauma-informed assessment? And really, ACEs are that first category. So trauma, loss, and history. When we're asking about adverse childhood experiences, we're asking about someone's trauma, loss, or history. So I love that we started there, right? That we are, I think, especially in our communities, doing a good job of understanding what exactly ACEs are and how they impact, you know, development and functioning. We're asking adults about them, we're asking youth about them, which is great. That is a great place to start. We want to go further than that, but I think if we're going to start anywhere, just knowing what a child has been exposed to can really help us to understand more context for a child's functioning. Does that answer the question earlier about ACEs? Where does it fit? Okay, great.
Would you recommend just going through these questions or doing the ACEs then? How would you recommend it?
So it depends on the setting that you're in and like what your long-term goal is with a trauma-informed assessment. If you're trying to simply screen or have these things happen to them, perfect. The ACEs questionnaire, asking them, you know, check yes or no, or just check which ones have happened to you. That's great. Now, if you want to have like a more trauma-informed assessment, you want to come up with a diagnosis, you want to come up with a treatment plan, you're going to want to do more beyond just the ACEs alone. If you wanted to take one step further, you would be looking at symptoms. So how do these situations that you've been through, how do they impact you today on a daily basis? So that's almost like that form the screener that you have in front of you, at the top is almost like cases. What have you been exposed to? What events have happened to you? The bottom is more so reactions or symptoms that you're having because of these things. It impacts my sleep, it impacts my mood, it impacts my behavior. Those would be like the one step above what you might be already at basis. So I'm not gonna spend too much time going through this. I feel like the previous slide, we spent a lot of time talking about that. I just thought it was another way to kind of outline the different domains, the domains being the top kind of italicized section, and then the key areas being right underneath it. And maybe you don't get it all of it. Maybe you don't ask anything about refugee trauma, or maybe you don't ask anything about racial or historical trauma because you feel like you haven't necessarily been trained and have had conversations about that yet. But maybe you feel really good about like asking yes or no if you've been exposed to child abuse. So just thinking through where you're at now and kind of where you can see you or your organization kind of go in that next step. So I also wanted to offer sort of a structure for how things look. And I wanted to kind of start with like generally starting with a clinical interview. So that's you meeting one-on-one with a child or a family and doing a clinical interview. There's lots of different clinical interviews out there. If that's something of interest to you all, I'm happy to like put that in the link later, where you have like different ways of just doing a clinical interview. But then after that, you're going to do some standardized tools and measures. So similar to the one that you have, there's other ones online that I can provide. And then behavioral observations. What is the child like with you? Or what is the individual like with you? Collateral reports or interviews. That's simply, like we said, getting information from other people in the child's life. Putting all that information together across sessions. And then assessing responses over time. So after you've done all of this, we want to be mindful that it's an ongoing process, right? That just because I've sort of outlined trauma one time doesn't mean that we're done, right? Just because I asked a question on the first time meeting each other doesn't mean I'm never going to ask it again, right? So you want to continue to ask questions or follow up on the child's sleep or any appetite changes or academic changes or their social functioning changes. You're going to continue to observe when you're meeting with the child, kind of noticing, do they seem restless? Do they seem like they're avoiding eye contact when discussing school bullying or discussing mom's new boyfriend, right? And we're going to record these over time. We might not bring it up right away, but we're going to be making note. That's the ongoing process. It's not just like we assessed your trauma. Yep, you have, a trauma history, you whatever, and we're done. We continue to have those conversations, and we might re-administer tools. Sometimes I administer the same tool I administered them 3 months ago that asks them about their trauma history. And they're like, I already did this. And I'm like, okay, well, just remind me, what things have you been exposed to? And they endorse completely different things. And you're like, huh? So that can be helpful data after they've built a closer relationship with you. They may feel much more comfortable endorsing symptoms or endorsing situations that have happened to them that they didn't feel comfortable doing 6 months ago. We also want to look at any symptoms changing. So when you're doing clinical work and you're monitoring treatment progress, every few months you want to track, like, is their sleep getting better or worse? Is behavior getting better or worse? And so using some sort of measure to assess for that throughout treatment is going to be really helpful. And that will then inform any treatment needs or goals that you might have to adjust. So this slide is really just there as a helpful reminder that you're going to be doing this all ongoing throughout your time working with the family. I'm going to jump ahead a little bit just for the sake of our time. I want to make sure we get to everything. So now we're going to talk about kind of zooming out and looking at trauma-informed screening and assessment through the lens of complex trauma. And if we're using a trauma lens, but not a complex trauma lens, we can sort of miss the full picture. We may misinterpret behavior or misdiagnose. So in this next section, we're going to move on to connecting what we know about complex trauma, how it develops, how it shows up in kids, back to what it means to actually experience. So kind of putting those two pieces together. We talked about complex trauma earlier, and now we talked about trauma-informed screening and assessment. Now we're gonna marry them and have some conversation about that. Before we do any discussion, I'm really antsy about showing you all this video apparently, so I'm gonna do that. I'm gonna show you a trailer of some short clips. All of them were developed by NCTSN's, the Center for Child Trauma Assessment, in collaboration with Northwestern University. The title is Remembering Trauma. It's accessible once it's on YouTube, so you should be able to have access to these after today as well. I do always like to start with a disclaimer that this film is inspired by true stories. It shows various ways that trauma impacts you. It contains adult language, it includes scenes of family violence and sexual assault, not in detail, but insinuating, which is hard to watch, right, for anyone, especially those of us that are impacted by our own traumas. And so just wanting to be mindful of that and like taking care of yourself, go get some water, stand up and stretch, and be clean. Eat. Okay. The first one is only about 2 minutes long, so.
I don't understand. And what you would think. Tell me exactly what happened. Nothing. Doesn't look like nothing. You know I have to submit a report to my judge. What were you thinking?
Hey, Bob. Seems like you've been having a hard time. You wanna talk about why you've been getting in fights? Not getting along with the other kids in your class?
I was thinking. I gotta do something. Well, you sure did something.
I mean, he's such a sweet kid, but he just seems to be having so much difficulty functioning. You know, he just seems to go off into another world.
So this is a trailer that will kind of refer back to that young man depicted in the story is Manny. And how many, like by show of hands, how many of you feel like I've seen Manny in the clinic, in the organization that I work at, in my neighborhood, in the schools I'm a part of, right? So let's start by having more conversation about that. Let me figure out how to get my. Okay. So, we need to pull up another clip that goes into more depth about Manny's experiences.
Go to the website.
For, yeah. What about that?
It's not as bad as it looks.
You told me this wouldn't happen again.
I know.
Should it busted again?
No, it's all good. Don't worry about it, babe.
I told you. I don't want my baby around when he's violent.
It was just something stupid. I don't even know what happened. I would never hurt our baby.
How am I supposed to trust you? You spoke the one promising me. You know, I don't want him to grow up with parents that got respect.
What are you talking about? You had it easier than I did. I'm so sorry. Look, all I'm saying is that I'm not like your old man, okay? I can be in control. Can I hold my baby now, please?
Go clean yourself up. I don't want blood on our baby. Eddie, you're not exactly give me your gun.
Here we talk to you, boy. Hurry up.
Eddie, diapers, please.
Don't make me get up.
Manny, did you hear me? Hey, bud. Seems like you've been having a hard time. You want to talk about why you've been getting in fights? Not getting along with the other kids in your class? No, Mandy. It's good. Fun. That boy's still picking on you. Yeah. Did you tell his boss? Andy, wait up. You have to stay close.
Hey, what's up, man? What's good, bro?
Those are kids. Don't hang out with them. Also, I've heard that you've been having trouble paying attention. Focusing on your work. You're willing to tell me what's bothering you?
Hey, what's good, man? Going on, my man? How's it going?
Keep my shoulder alone.
Girl, how you doing? What are you doing? Oh, I did.
Fanny. Fanny. Fanny, you're not in trouble, okay? I just want to know what's going on. Oh,
Where you go? Where you go? Stop.
baby. Oh, hi. Yes, thank you so much for getting back to me. Yeah, so the reason we're recommending testing is we're kind of confused with what's going on. I mean, he's such a sweet kid, but he just seems to be having so much difficulty functioning. Yeah. Okay, I mean, he is hyperactive. His teacher keeps coming to me and, telling me about all of his learning problems. She seems to think that he has ADHD. But, at other times, he just seems to go off into another world. I'm just starting to wonder if it's maybe something developmentally. Yeah, but I mean, there's other times when he just explodes and gets aggressive. I'm just starting to think that maybe given his family history that it may be some form of bipolar.
Yeah. Thank you so much for taking the time to get back to me. I hope this helps inform your testing.
Track progress toward my goals with it.
Go ahead and talk with each other about what do you see or suspect in terms of trauma experiences for Manny? They're kind of, remember that first domain that we had, it's like trauma loss history, what, or ACEs even. What traumatic experience, just from these short clips, can we kind of put together for him? If we were doing a training, what things could we capture? Talk to each other, kind of make a list and put it together.
He probably has a lot of trust. All the, because like those guys were probably one of the first people to be kind of senses. And then, you know, watched.
Yeah.
So. What do we think? Let's shout out traumatic experiences for Manny. What do you think here? If you're the clinician and you have this bird's eye view of this kid's experience, what sorts of things has he been exposed to? Probably
Domestic violence,
domestic violence,
poverty,
poverty. That's a great one. It's not even to pick up on that one. It's really good.
sexual attack, so let's say.
So witnessing sexual assault and vicarious symptoms he might be experiencing from that.
Yes.
Verbal abuse, good.
It reinforces the sense of helplessness.
Yeah. Reinforces the sense of helplessness. I can't help anyone. I can't help myself, maybe. Yeah, that's great.
Yeah, all the environmental factor, the trauma, him gravitating to the older guys as a means of seeking safety.
Yeah. So looking up to these older guys, the other older man he has in his life is abusive. And these two older guys, you can see him kind of brighten up when they're like, hey, man, he's high-fiving them. Yeah.
Codependency.
Say it again.
It's a codependency within the whole.
Codependency, yep. And these are all things that Manny, I don't know if he's a teen or adult, he has a baby, he has a partner. he comes in, I didn't show that part, I kind of may have messed it up for you all, but you can watch it. He ends up, he's going to the grocery store and he ends up getting into a fight with a bunch of guys who were trying to assault a young woman. And so he comes home and he's already on parole and he looks a mess and his girlfriend is like, I don't want you in my house when you're acting like this. Understandable, right? But oftentimes we see the older Manny, the adult Manny, we don't always get to see or understand or have an awareness for all of the exposures that Manny's kids are exposed to, right? Next point of discussion I want to have is what labels or diagnoses did you hear towards the end there? Bipolar, ADHD. What else?
She also mentioned developmental.
Developmental something, right? Learning disability, right? So we can see how complex trauma, this chronic exposure to violence, interpersonally between him and his dad, between watching him and his dad and mom probably fight, between what's happened with his sister, who probably is a strong kind of caregiver in his life. All of that is that interpersonal trauma combined with poverty, combined with potential neglect. All those things are shaping his experience. And in the classroom, we're seeing it as a behavioral thing or an aggressive thing, and immediately suggesting ADHD, bipolar even. So I hope that that's a sign to you all. If you see, and I'm jumping a little bit ahead, but if you come across a child, a teen, even an adult, honestly, who has ADHD, bipolar, depression, PTSD, right? There's likely complex trauma there, right? That's impacted them across their development and is now looking like all of these diagnoses as opposed to complex trauma. There are some key messages from the Remembering Trauma films. We had more time, we watched more of it together. But I think the first one we kind of hit on already together is that complex trauma reactions are often mislabeled and misdiagnosed. And I'm curious from the work that you all have been doing or just being exposed to, is that oftentimes kids are diagnosed with ADHD or oppositional defiance disorder, conduct disorder, even reactive attachment disorder, which I think is like, okay, you're at least understanding with reactive attachment disorder that something happened in the child's like caregiving life that impacts their function. But we don't have a complex trauma diagnosis. So I understand why a lot of folks have a hard time coming up with like, what do we do with this kid? They have a long history of trauma, especially interpersonal history, especially early on in their life. And now they're showing all of these like behavioral, developmental, learning, aggressive behavior, mood issues. They're in court involved, right? They're in juvenile delinquency stuff. There's a really strong chance that kids being exposed to or who have or meet criteria for complex trauma are often being misdiagnosed or mislabeled, right? And I'm sure we've all seen it in the work that we do. I wanted to, provide another illustration. It almost feels like it's a maze that we're on when we're trying to assess for complex trauma among youth, because we're like, they came in because they got in a fight at school, but I also found out they're using substances, but also they seem really low, like their mood seems really down, but also they're really defiant, not all the time, but towards men especially, right? And so you're then kind of in this maze of trying to figure out what exactly is happening here. And sometimes the last diagnosis is PTSD, or they don't meet criteria for PTSD, right? I have a whole separate lecture on PTSD and the history of PTSD and how it's not a really good fit for most kids or teens or even some adults. So most often if you're assessing for trauma in kids, they probably aren't going to meet criteria for the formal DSM-5 criteria of post-traumatic stress disorder. So that's what's really frustrating about our system a lot. Our goal is to look at their entire experience, right? through a different lens and have this awareness that complex trauma could be at play here, right? And we can still add this, that like, sure, on paper, they may meet criteria for these things, but given their history, given all of these exposures they're having, it likely is not going to be addressed with ADHD medication or just treating depression or just treating substance use. I think this clip is very helpful. I'm going to find it also. Keep thinking I'm stuck up here, but I'm not.
I think the potential for misdiagnosing trauma or the effects of trauma is something else are quite large, especially with children and adolescents. Things about trauma, I think, is that the reactions to trauma fluctuate. One day a child might look very, very subdued and withdrawn and appear depressed or even developmentally delayed. And another day they might look out of control and hyperactive as though they had ADHD. Our biases as clinicians come into play here. So certain individuals may have more experience working with one diagnosis or another, may have more experience with children who have developmental problems and have bipolar disorder. And so those biases may cause us to sort of see the thing that we're looking for.
When people hear the word trauma, they think about PTSD, but really it extends way beyond PTSD. And in fact, if you look at the research, about 70% of people that have experienced a traumatic event don't actually go on to develop PTSD. Many of them experience difficulties, cognitive, behavioral, emotional, physical symptoms that extend beyond that. And a lot of those symptoms oftentimes are consistent with other diagnoses, including ADHD or bipolar disorder. So there could be some confusion. And what ends up happening is that a lot of these children are receiving multiple diagnoses. And in addition to multiple diagnoses, what often goes along with that are multiple treatments and multiple medications, each treating very disparate kinds of things. So when you look at the symptom picture, you're seeing lots of different symptoms. And so you start treating these different symptoms as if they're not related to one another. So you might be treating the bipolar, or you might be treating the borderline personality disorder or the ADHD, and people aren't really looking at the entire clinical presentation through a trauma lens.
I don't know what's wrong with me. I get pretty angry sometimes and nothing can calm me down. And I've heard it all. I have conduct disorder. I have bipolar disorder. There's probably not much you can do to help me anyways. But people keep asking me what I'm gonna do about it. And I don't know. I don't know what I'm gonna do about it because I can't get any help anywhere. And I've tried all the different meds. And the fact is that they just kind of numb me out, but they don't really help me get over anything.
One thing that is quite common to see in children.
I'll stop there for that part. I want to give you all maybe a minute to think through what kind of diagnoses you come across the most in your clinic. And do you feel like those fit? Or are you sitting here like, maybe it is complex trauma, maybe there's a trauma history there? Have some discussion with each other.
With the brain, I don't,
What kind of diagnoses come up in your work and are they really bad or now you're like, this is, I'm seeing more complex trauma than I think. Yeah. We have a lot of like conduct disorder, obviously we can define it as those are like the three main ones that we work at a residential facility for average. Yeah, 14 days. And so those are like the three main ones. But yeah. I mean, I would be confident in saying like 85% is complex trauma. Yeah, a lot of mammies in your work. Yeah.
It'd be nice if they could just give that diagnosis because ODV blames it on the child. It's their behavior. Where we have a diagnosis of complex trauma, you'd be looking at things that happen to the child as opposed to what the child is doing.
Yes, yeah. Right, I think it's Bruce Perry or someone coined the like, what's wrong with you is the wrong question to be asking. Instead we're asking what happened to you, right? Yeah. Yeah. You only have 10 minutes left, yeah, but went by so fast. I was like hours of standing and 35 filming. I can't do it. Yeah. Thank you all for your engagement. I do want to spend a very short amount of time, and I'm sure Lisa may have like last minute things you want to go over. Should I give you 2 minutes?
Just 2 minutes.
Okay. Some contextual considerations. And really it's just like, what does this actually look like? Like laying the groundwork for trauma-informed screening and assessment in your actual places of work. One, thinking about training. So offering training on different trauma types. So RAD, right? Reactive attachment disorder. That's a very specific kind of trauma diagnosis. And can spend, 2 hours of a training just on that. Like, how do you assess for that? What are the treatments out there for that? So just thinking about what are the kinds of kids you're interacting with or families you're interacting with, and what sort of training might be most helpful when you're thinking about the screening and assessment process. And then we want to think about safety. So creating emotionally safe environments where your clients feel safe when they're doing their screening and assessment process. And when we think about safety, one thing that I think comes to mind in our clinic that is very straightforward is organization. Like being structured. So many families that are impacted by complex trauma have such chaotic lives, and our organizations are doing the best that we can with what we have. And I think because of that, our resources and the way we do run procedures, like, oh, are you doing this? I don't know, am I doing that? And it's just kind of all over the place. One way that we can enhance safety for our clients is being very organized, starting on time, ending on time, which is why I will end on time. Being very clear about like what it is that we're going to do today, how long I'm going to be spending with you versus mom or dad or caregiver, whatever it is. These are the forms I'm going to have you fill out. They're right here. Here's your pen. You can sit right here. The restrooms are right here. Water is right there. So being very clear just about the physical space and how they're going to be spending their time with you. This comes down from like the person that's actually doing the work all the way to like the first person that a client sees when they walk through the door. Everyone should sort of be on the same page and be trauma informed, which goes back again to training and how to do that well. And then we think about relationship building. So facilitating referrals for assessment. So maybe you don't do the full assessment. Maybe you don't provide the treatment. Maybe you don't even do the screening, but you're starting to think like, okay, because I know this is a part of the population I work with, I need to make sure I have the resources to refer them to the right places to go to, or what resources are available in the community that I can leverage for my organization. And then thinking about prevention, I think the least we can do is prevent people from experiencing traumatic events in our spaces, right? So being aware of like how to prevent traumatic experiences, how to have open, very clear communication with our patient population. And then thinking about how to create physically safe environments, being well lit, having it safe and secure, having a private confidential space, having crisis protocols in place, providing calm, non-threatening communication or tone, giving families advance notice and preparation for things, using open-ended and clear questions, avoiding assumptions about the impact or meaning of different events they've experienced. We don't ever want to assume that a family has experienced a specific kind of trauma based on what they look like or based on what we know about their family system. And then, of course, we get to things like the role of culture or identity in trauma-informed screening and assessment. And I'm sure this could also be its own training. And I know MHAM has done a great job with like trying to do even more of this. So grounding your work in cultural competency models. So the addressing model is a beautiful model that I expose my trainees to. I can give you all access to it. It helps you reflect on your own identities and how they shape your interactions with the patient populations you work with. Thinking about cultural humility, practicing openness and self-reflection. All of this is going to impact how effective you are at being trauma-informed. I sort of have this approach that you really can't be trauma-informed without also being culturally responsive or culturally humble. And so we can talk more about that if you would like after our time today. But then applying it to practice. So asking about identity or values or the community during your assessment. Collaborating with the caregivers to interpret findings. So I might tell a caregiver, you know, this came up. Tell me what you think about that. Or tell me from your perspective, from your faith background or your cultural background, how that impacts your engagement with me, your engagement with the system. You want to balance your clinical expertise with cultural expertise to understand the full story of a client and their experiences. And I talked a little bit about some adaptations. So being mindful that all of this is going to impact whether it's a younger child or an adolescent, whether it's a child with an intellectual or developmental disability, systems involved youth, LGBTQ plus youth, people of color, indigenous people, immigrant and refugee families. This is all going to potentially impact the way that we go about talking about trauma-informed screening and assessment. And the very last thing I wanted to leave you with, if you're like, okay, this all sounds great, Taylor, Dr. Nicoletti, but I don't know how to actually do it, what this actually looks like. So we have limited staff time and resources. So maybe you leave today with like one key concern or one key priority. So you don't feel like, oh, I have so many things I need to figure out. I'm not doing it. Our organization isn't doing any of this. Maybe it's you just offer one additional screening, right? Maybe you're feeling like, oh my goodness, we are at the risk of mislabeling or misdiagnosing. So maybe you have just a more of a understanding of a complex trauma lens. And sure, on paper, it says they have ADHD and all these things, but the way that you engage with your client is from a complex trauma lens, knowing that this behavior is much bigger than you just getting into a fight with a kid. Or maybe you feel like you have insufficient training or you need more consultation. You can seek that out. You have my email, I can refer you have MHAM, which is a beautiful, amazing resource to invest in, to be a part of. So advocating for resources in your organization. And then also if any of you are in any sense of power within your organization, thinking about how do you get more training involved, where people can come to you and offer more expertise or consultation on specific issues that you're having. I have left some key resources, primarily a textbook that I think is really helpful, as well as the website that has additional, like all of my content came from NCTSN and the work that they do, so you'll be able to have their information as well. And then you have my contact information. I always tell folks, I am a therapist, I'm not your therapist, so you're welcome to email me. And I'm happy to provide resources and support. But don't email me at 9 o'clock at night for coping strategy. Thank you all so much. I'm happy to stick around for more questions.
Hi, my name is Jan Marable. I'm the Director of Community Outreach and Education for MHAM, and we'd like to thank Taylor for the presentation today. We also want to thank you all for coming. We want to encourage you to please do the evaluation. Doing the evaluation helps us to not only have great presentations like this, but your feedback to help us to do what we do even better. So please take just a few minutes and do the evaluations for us. If you are getting CEs, continuing education for this presentation, please make sure you do your post-test, your pre-test, your post-test, and the evaluation. It takes about a week to get your certification, but you need to get all of that in as soon as possible, because if you don't have it in, then you won't be able to get your CEs. Also, we'd like for you to stop by the MHAM table, pick up some information about who we are, help spread the word. We do have Journey of the Mind art exhibit that's coming up for high school students that are artists, or for any of you that are artists. Please share the word. We will have a traveling exhibit this year, 2025, we did it in Elkhart, but 2026, we're taking it on the road. And so it'll be in Elkhart for a couple of weeks, and then it'll be in St. Joe County. So we encourage you to help us spread the word. It's a wonderful opportunity for people to express the mental health journey through art. And so we're excited about it. Very successful this year, and we're looking forward to another great year. I think that's it for announcement.